Welcome to the SUDAcare podcast series. These are conversations that strengthen prevention, referral, and recovery for substance use disorders by working through Nigeria's most trusted systems, the faith-based institutions like churches and mosques, traditional leadership, and community networks. Today's episode is Spotting the Signs Early, Youth Mental Health, Substance Use, and SUDAcare Pathways. My name is Clinton Eziani, and I am the US lead for SUDAcare. And I am joined by two incredible clinical psychologists who have lived and worked in Nigeria, who understand the realities that people face every day. Thank you both for being here. Can you introduce yourselves?
I am Paul Nibichukwu. I'm a clinical psychologist, a brain re-engineering expert, and a human transformation architect. Currently, I work in a psychiatric hospital. Also, I'm part of the SUDAcare program. So we're here to enhance and ensure that we contribute actively towards reshaping society at large. Thank you very much.
And before Dr. Nelson goes, Paul, what sort of patients do you work with each day?
Yeah, basically, we see a lot of patients ranging from the likes of SUD cases. For our viewers or listeners who aren't conversant with what I've just said, what that means is, in full, it's called substance use disorder. But of course, I like to clear the air. We have substance users, and then we have substance abusers. And of course, those guys who abuse substances are those who have issues at the end of the day, thereby developing what we call SUD, substance use disorder. Thank you very much. And of course, like I said earlier, we see a lot of patients. So of course, other mental health issues, the likes of anxiety, depression, etc., emotional distress, or whatnot. We attend to all of these cases. Thank you.
Thank you. So we see Dr. Paul is someone with extensive experience in this field, in clinical psychology, and working with people who have experienced substance use disorders. Okay, and Paul, while Nelson is joining, I wanted to ask you guys to start us off. Like, what are you guys seeing today in Nigerian youths and their substance use disorders, and how they are dealing with that? What does the landscape look like right now?
Honestly, to be very candid, we're seeing or noticing a growing increase. It's like a global menace already. You know that, so we are seeing a growing increase in the trends, for which individuals consume certain substances, without any iota of control. You see, in Nigeria today, many young people are not, most times families, guidance, support networks, and etc., they tend to say, oh, this guy is just misbehaving, this guy is just acting up, this guy is just doing this, and that. But really, to be very, very candid, the individual is not just misbehaving, because they are actually acting in their sane mind, in quotes. What do I mean by this sane mind? I mean, just the way they think, that is how they act. So they are signaling some form of distress. But because of the stigma, because of maybe misunderstanding, and because of maybe the subtle approach with which those responses, present themselves, we might tend to, either as guidance, support networks, etc., respond late or respond incorrectly in the sense that we might not actually be providing the much needed guidance or support as it should be, right? And that could actually, lead to some kind of increase consequences. If you understand what I'm trying to say.
Yeah, that's that's
And
that's that's very interesting. Yeah,
yeah,
because
yeah. So
it's
yeah,
a
so
growing
that's
trend.
it. Yeah, that's it. Because the more I used to say these things often. I say it often in my practice over the years and from experience or my experiences. Right? I say many persons actually delay seeking for help or assistance where necessary. You know, and when it gets to a certain point where you've crossed a certain threshold, intervention will definitely be expensive, you know. And there could be
Mm.
some kind of emotional, social, and sometimes fatal consequences affiliated with the delay, you know, that you might not be able to return back to normalcy or finding that balance after that, long time delay or something of that sort. I don't know if you understand what I'm trying to say.
That makes sense. Yes, because early intervention is very important. Like the longer it takes for the person to seek help or for people to intervene, the worse the issue becomes. Um,
That's right.
but yeah, I think we have Dr. Nelson back in. Even though we had some network issues, but Dr. Nelson, if you're back, can you introduce yourself? Tell us who the people you work with each day, and also the trends that you see today in with Nigerian youth and substance use.
Okay, thank you, Mr. Clinton, for the opportunity. My name is Nelson Wankwo. I I am. Can you hear me?
Yes, we can.
Okay. MSc Psychology and Clinical Psychology in PhD. I'm also a teacher. I also work with Delta State University, Abraka, and I've had experience in the field. Well, uh, in regards to your question about early intervention, it's very important. In fact, one of previous years we have conducted a research that looked at some of the psychological factors that precipitate drug use, and we also discovered that most of these psychological factors like psychological vulnerability, rejection sensitivity, and low self-esteem, that without early intervention, that these these psychological factors could even lead to a more devastating or chronic um, situation in which these people had to live with this condition for the rest of their lives. So early intervention will help to uh, prevent the situation, any or drug use or substance use from going into a more chronic stage. For example, in 2024, rather, we did a kind of randomized control study where we used individuals with substance use disorder as a sample, and we tested some intervention that we found to be very effective, even to be very effective than the traditional CBT. The work is there online. RET, we call it rhythmic engagement therapy. So what I'm trying to say in essence is that early intervention is is the hallmark of treatments. Let me put it that way, because without early intervention, some of those substance use can even progress to addiction or substance use disorder, like what DSM-5 TR. So early intervention will help us to mitigate, to checklist those potential risk factors that would precipitate substance use and also threaten the sustainable development of the society. Thank you.
So, thank you, Dr. Nelson. It's true. Early intervention is very critical. Um, f- for let me pose this to you. So, when people want to say, okay, now now that early intervention is very important, early detection, what can I be looking for? So, what are some maybe two or three behavioral or social signs that a young person may be struggling, that maybe faith leaders can notice, maybe in the church or parents or just community leaders can notice? What are some behavioral signs?
Yeah, thank you very much. Thank you indeed. There are a lot of behavioral warning signs that faith leaders, teachers, and other community-based practitioners should look for. They include um, something like changes in a routine activity. Some people that use drugs, they have these sudden changes in their routine activity. For example, they might started if they are students, they might started having all these disciplinary issues, conflict with the teachers, late coming, and the rest. Also, there are some emotional or mood swing that those people used to exhibit, like excessive anger. They used to have this excessive anger, irritability, sadness that are not associated with anything. They might, suddenly get flamed up. Also, they may have something like sleep disturbance. They will not be sleeping well. Another thing is the peer influence or the peer pressure that they roll with. Some of them might change. You might see them going out with older or younger peers that are involved in those activities. Another one is also they have this resistance. They have this increase or decline in self-control. They might easily get, tempered and, angered with slight thing, something that doesn't amount to for them to react in a certain way. So another one is also uh, trying to put up defense. People that use drug, they're always trying to find reason. They will tell you, they will give you reason. Maybe I use it because of this. I use it because someone got me angry. I use it because I had an issue with this person. They must have this. They always try to put up defense.
Mhm.
So that is it for now. Thank
Okay,
you.
okay, that's true. So that's a good way. I think when you see all these changes, you can kind of tell, you can identify that something is off, something is not right here. Um, so my next question, I'll pose it to Paul, to Dr. Paul. So now we've moved from identification, and now is the time for connection to help. This is the SUDAcare referral, and SUDAcare's mission is to make sure that when a faith leader, a community leader, a traditional leader notices things concerning, they are not left alone. They don't know. They're not it's not that they don't have where to turn to. There's a clear pathway that they can turn to. So, Paul, let's say a pastor notices something. What next steps can they do? And um, um, how can SUDAcare come in?
Okay, great question. Great question asked. But before then, you see, I would like to add to what Dr. Nelson had said earlier.
Okay.
The truth is, early intervention is not necessarily about diagnosis, but then it's about spotting, the ability to spot or to be able to signal spot on the gradual decline in normal functioning. So, for example, you have a child or a chap who is your child or something of that sort, and you know how this person behaves over time, their daily routine, how they act or what they do, and suddenly you see a deviation. You should be able to spot. I guess the idea about this podcast is for people to be aware, to be self-informed, so that they can understand how to mitigate and navigate, this challenge, which is ongoing. It's a growing challenge. So the idea is to be very observant of your words and to know when maybe one or two things are happening. Now back to your question. The truth is, first of all, the best approach to this is, to be emotionally sensitive and aware. In fact, in clinical practice, it's something we usually say. We talk about having unconditional positive regard. For each of our clients, we are trained to have unconditional positive regard, meaning to say that, despite the tantrums that you witness, because I can tell you for free, working in this line of practice is not a walk in the park. It's not actually an easy thing. We've had cases whereby we see a patient tear the what do I call it now? Jack the counselor's shirt. You understand what I'm trying to say?
Mm-hmm.
Become very aggressive with you, and then
Mm-hmm.
what do you do in that context? In fact, personally, I have a personal experience of when in trying to provide some form of support, somebody threatened me with a knife that he was going to, kill me, something of that sort. He tore my shirt. I mean, I was apparently naked. I had to go to a store nearby. Yes, real life example. I had to
Wow.
go to a store nearby to get some new shirts, new clothes to put on. But that also gave me an insight into how to manage, such a client. So it's still in line with the question you've asked. You have to be emotionally intelligent and
Mm-hmm.
very, very aware and sensitive when dealing with such issues. So don't try to sound judgmental as a
Okay.
pastor, probably, or as a faith-based leader. Don't try to sound judgmental. You can use questions that have some form of emotional appeal, so that you can actually connect to the individual you're trying to pass a message to. You understand what I'm trying to say? So that you can get their attention, and then maybe that way you can get to inquire. Get some stipulated questions, what exactly you can do for them, or how best you can channel them to the right source. That's in the case of referral now. Yeah, so
That's
I think
that's
that's it. Yeah.
Yeah, thank you. That makes a lot of sense. It's because after identification, we see that there's a lot of disconnect to the next step, to the referral step. There are a lot of barriers, there are a lot of things that come in between the person getting the help they need. And sometimes those things are just societal. It could be stigma. Oh, you notice they notice in the church someone has been noticed being using drugs. People start to avoid, people start to shun the person. That is the destigmatization of the thing, which is a barrier. And then there's a break. That person cannot get the help that they need. There's no pathway through that. There is also, like you mentioned, being emotionally sensitive. You can't just, because especially when someone is going through substance use disorders, it also triggers other issues, sometimes mental health issues. And if you are not emotionally sensitive, if you are not in tune to it, you might not be able to make that referral possible. And that is something that, at SUDAcare we're very we're focused on making that possible. Dr. Nelson, do you have something to add to that?
Yes, I do. Actually, I want to thank Dr. Paul because he highlighted some of the important issues. He pointed out that he has encountered a violent client who also tore his clothes. I know in such case, let me just use Paul's example. In such case, if a client or if you notice that a client has this aggressive tendency, when I was trained, sometimes if the aggression is can be counter transferer or transference of, you can refer. It's very important to refer. There are some, you have to do your own homework, refer the client to a professional that are skilled in that background, that are skilled in addiction, who can help the clients. Also, some clients are very, especially people with SUD, substance use disorder. They are very, I don't know, they are very corny, or they are very clever. Let me put it that way. They're not smart, but rather clever. They want to manipulate you. They want to turn it to their favor. It has happened even when I was doing my internship, clinical internship. I met some of them that were trying to pose questions. We are trying to see, who you and tell you that they don't believe in this thing. They don't believe, they try to put themselves in a light, in a favorable light. So uh, it's very important to know the theoretical background or the client's situation, and immediately that you identify that this situation is our signs or symptoms of this situation, you can always refer. It's very important to refer to a professional that can handle it very well. So thank you.
Yeah, thanks. Thank you, Dr. Nelson. That makes a lot of sense. So, let's go moving on to the last part of our discussion. I think I want us to just talk a little bit about the Nigeria's trusted system. So the way the parts where SUDAcare is choosing to work through churches, traditional leadership, mosques. How can these systems support prevention and recovery, while staying within scientific boundaries? Let's say, um, what are some activities in the church or in the community that can help um, prevent youths from going into substance use disorders? Let's say group activities, things like that. What are some things that you have seen in communities or in churches that um, we believe can support um, recovery and that reduces the risk of relapsing?
Okay. Thank you very much. Wonderful question. I'll answer the question with a scenario of what happened to a particular client that we attended to in 2024, 2024. There was a client that came to us for, the mother came to one of the psychologists. Then, while attending to the clients, I observed that the client has a very negative belief about the family, especially towards the mother, even attempted to kill the mother or to hurt the mother. He said publicly that once he's out, he's going to hurt the mother, can even take his life. Then, at a time, although I referred the client to NDLA, who later handled it, and he made some paperwork to ensure that he doesn't take it up. Then, the faith base that was involved in that situation, the church, the pastor was there to encourage the client. First of all, the whole thing was identified by the community, a youth leader in the community. He spotted that the guy was, being secretive, going out at night, doing all sort of things, going out with some particular friends that are not good for him. So they spotted that and informed the parents, and the mother was a civil servant. Now took the action, seek for help, call professionals involved to assist. And before the guy would have taken any action, the guy was apprehended and brought to us, and we addressed it. But today, thank God, today the guy has fully, let me put it, the guy has recovered. He's a functional human being. He's working. He's doing well. So, based on what you asked, how those community leaders, faith-based, and the church leaders would help, they would assist by, identifying these people and also identifying some of the risk factors, because most of them they belong to a certain religious denomination. The church can do an outreach to those members, call them to know their situation. It's like let me call it is a first aid care. They would try reach out to those people. Community leaders should reach out to those people. Teachers should reach out to people that they noticed unusual behavior. From there, once from their own interview or from their own observation, once they observe that those people are high risk individual, they can refer. They can work with the community leaders to refer these people to the appropriate authorities, especially SUDAcare will now take it up from there. They will now, refer, suggest a best way to handle those people. So thank
Thank you.
you.
Yes. Paul, do you want to chip in
Yeah,
on some ways that the
thank you
community
very
can
much.
support?
Dr. Nelson has hit the nail on the head. However, let me just say one or two things. You see, the truth is, I want to even say this. When it comes to SUD, managing SUD cases, you see, it's a lot different from normal mental health challenges, the likes of anxiety, depression, OCD. In fact, I'll tell you, as a matter of fact, we've had a case where there was a comorbid, it was a comorbid disorder kind of issue, OCD, comorbid substance use related disorder, kind of. It was that bad to the point that the guy tried hanging himself,
Oh,
and was very irritable and very aggressive with everybody around. He would not want to conclude, but eventually, somewhere along the line, he got better. So realistically speaking, you might try your best, trying to salvage that situation. However, sometimes it can get very, very difficult.
mm-hmm.
I get the part where Dr. Nelson mentioned referral. That is very critical. But sometimes, okay, imagine you have a client, and you've been attending to this client for quite some time. Everything seems to be very smooth. I don't know if you get me. Very smooth, no challenge, nothing is happening, and then suddenly the client switches on you. So something of that. So that's exactly how SUD clients are, and that's why when Dr. Nelson mentioned they are not smart, that he said use the word, but I like to say that they are smart actually in a way, because those guys, they can be
Mm-hmm.
very corny actually, if you're being honest to ourselves. So back to what the focus is, right? So you see, for pastors, faith-based leaders, there's something that is common. And you see, the churches harbor large gatherings. There are a lot of people that come to church, and so when they come to church, they're expecting to get some kind of succor, relief, from their pain, from their trauma, from their anxiety, from their depression. But then you go to church and it's like they are taking from you. They are not giving you. You're not feeling inspired. You're not feeling motivated. You're not feeling energized as should be, which is a big problem in our society today. So I don't know if you're listening, you're hearing me,
Yeah, I can
Mr.
hear you. I can
Quincy.
hear
I
you.
don't know if you're hearing me.
Okay.
All right, great. I just wanted to confirm. So back to what I was saying. So one of the ways our pastors, leaders in churches can actually assist, you know, is to at least dedicate a time during the course of their sermons in church. Dedicate a time whereby you, like, from the pulpit, you know,
Mm-hmm.
you in your sermons, in your messages, you inculcate, that is, you chip in something affiliated with mental health. You get what I'm trying to say? Something affiliated with mental health, something affiliated with this condition that we're actually centered
Mm-hmm.
on, we are focused on. You chip in those messages, and then you can say something like this. The message could go something like this. Um, you know, I know you might be struggling with one or two emotional issues, battling with one or two, battling with an addiction. Let me put it straight on. Battling with an addiction. I want you to understand that it's not a spiritual failure, something of that sort. It's a human experience. And then seeking for help is not a sign of weakness, but it's wisdom. You understand? So the moment you're communicating this way, as you're communicating this way, you are shaping the narrative of your audience. Your audience are beginning to get a different take or narrative about the whole context or situation at play. You understand what I'm trying to say?
Okay. Yeah.
Yeah, and then in a nutshell, or by extension, it reduces the stigma so that people feel more
Over time,
comfortable going to church.
they've talked
They
about
feel
it
more
in
comfortable
church. They've
going to church.
mentioned it, so you
uh
can just
They
bring it
mentioned it,
up
so
with
it's
somebody. Oh,
exactly,
this and that.
that is
Mm-hmm.
it. That is the point. Then for teachers, let there be a behavioral shift. Sometimes it's good to just observe, maybe at random. You pick maybe two or three students and say, okay, though the students you have observed over time, that there's, just like Mr. Dr. Nelson mentioned, he talked about, the three phases. If you want to look at the areas for which you measure some form of deviation, you know, from normal way of functioning. You look at the behavioral aspect, emotional aspect, and functionality. He mentioned all those things by citing examples. So when you look at these three constructs, you can say, okay, who are for the teachers now? You can go to school, in your campuses. You can say, okay, which of these students have, constantly deviated from the norm? You spot them out and you take it. You see, this is about, it is more like a responsibility. I understand that many of us don't like to take on responsibilities, but this is more like a responsibility. It's like a tax that we all who are involved in it have to dedicate our time and be compassionate about it. It can get draining sometimes. It can get draining. That's a fact. Everybody should know this. I can imagine having a client whereby you brought a client into a rehab facility and the guy, he or she is treated for substance use disorder, and then it's almost like 6 months of treatment is rubbish. Let me use that word in quotes. That is, it doesn't make sense. It doesn't count. It doesn't apply. And the man, the husband, the father, the wife, they get frustrated. But that shouldn't be. Because if the professional is trained to have some form of emotional empathy, the same should apply to the guardian, the ward, the support network, or team members who are interested in seeing that this individual gets better or gets some form of help. Because if you give up on this individual, who is going to take the shot for him or her? So in other words, what you're saying is that when you give up on him or her, automatically you're sending that person to the streets. You know the implication of that already. So the empathy has to be there. It has to be inculcated or infused into ensuring that we get the best out of such clients or individuals who present themselves. And this also applies to traditional heads, traditional leaders, and all, because it's the same approach. So the moment that form of emotional understanding is built, I think that every other thing can flow in smoothly without much challenge or much issues. Thank you very much.
Thank you. Yeah, it has been very enlightening. That makes a lot of sense. I think today there are many things that the pastors, the churches, the community leaders can do to help connect people to getting the right help that they need. So thank you, Dr. Paul. Thank you, Dr. Nelson. Your experiences have been very enlightening. To the listeners, you don't have to handle it alone. SUDAcare provides clear culturally respectful pathways for prevention, referral, and recovery. Check the episode notes for the link for resources on our website. And I'm Clinton again. Thank you for joining us, and we'll see you in the next episode.